Very good. Today we have Dr. Amy Cook presenting on obesity medicine and how we can incorporate that into our primary care practices. So Dr. Cook is a Sioux Falls native. She attended SDSU for her undergraduate studies and University of Nebraska Medical Center for medical education. Then she completed family medicine residency at the Sioux Falls Family Medicine Residency. She now practices in Brookings, general family medicine with prenatal care and obesity medicine. She lives in Brookings with her husband and 2 kids. Early in her practice, she recognized a need for additional weight management services. And so she pursued obesity medicine certification and became a diplomat of the American Board of Obesity Medicine in 2019. So she is joining us from Brookings today. Now, if anybody has any questions along the way, feel free to enter those into the chat. And Dr. Cook should be able to see those and answer along the way.
Can you hear me okay?
Yes.
Okay. I have the chat pulled up, so you can, if you need to interrupt me, just send me a message on there and I'll be able to clarify the presentation. But thank you for having me today. I'm really excited to be able to talk about this topic, as I'm very passionate about both primary care and obesity medicine. Let's see. I don't have any disclosures today, but I am going to mention that I am a member of the Obesity Medical Association, and I will be referencing their obesity algorithm frequently today. And it is a good clinical resource for clinicians that I'll have some more information about at the end of the talk today. Now, we could go on for hours today about this topic, but we'll try to cram in the most pertinent information in the next 45 minutes. So we're going to touch on the bias that's related to obesity, and we're going to try to identify obesity as a disease, and then recognize the comorbidities that come along with obesity, and then start to develop a comprehensive approach to obesity treatment. So to begin, we'll start talking about obesity bias. Obesity bias is going to be the negative related attitudes towards obesity. It's basically everywhere and under-recognized. People who struggle with obesity are often viewed as lazy or lacking willpower or making bad choices. People are judged and stigmatized through all aspects of their life. In the media, I'm sure we're all familiar with the weight jokes in shows, and then in news, when they address obesity, they often destigmatize people with obesity by cutting off the head when they're showing images and just making it the body of the person. In relationships, people are judged by their parents, their own kids, their significant others, friends, co-workers. In education, there's bias related with the teachers, and there's been one study actually that shows that kids who have obesity have the same quality of life as those with cancer. And even in work, people are stigmatized by weight, as they are less likely to get promoted or get raises compared to a person with a normal weight. And in healthcare, we are not immune to weight bias. There's been studies that show that about 1/4 of nurses have felt repulsed by obese people, and that 1/3 to 1/2 of nurses feel uncomfortable caring for patients with obesity, and about 1/3 would prefer not to work with patients with obesity at all. As for physicians, about 50% or half have made patients feel uncomfortable or biased during an encounter, and upwards of 70% of physicians have used language that make patients uncomfortable. And I'll have to admit that before kind of recognizing bias, I was guilty of it myself too. So we're going to try to identify ways to help combat obesity bias and weight bias, which first we have to recognize it as a bias. And then we can rethink obesity as a disease and not a choice. If there's one thing that you take away from the lecture today, I encourage you to adopt people first language, which helps to dehumanize or to prevent dehumanizing the individual as their disease. So we don't say it's a cancerous patient, it's a patient with cancer. Instead of saying a diabetic patient, it's a patient with diabetes. And along that lines too, it's not an obese patient, it's a person with obesity. So this is straight from the Obesity Medical Association with encouraged and discouraged terms to help with the people first language. So using weight, overweight, body mass index, as opposed to labeling as obese, morbidly obese, fat, weight problem. And I would even put in here that discouraged terms can include diet and exercise also, which have a negative connotation to it, and instead use more of nutritional plan and physical activity instead of those. This is also from the Obesity Medical Association. Going further than just the language, we can provide a comfortable environment for patients that are non-biased so that it is safe, accessible, accommodating, comfortable, welcoming, and non-shaming to people with obesity. And this really should be the norm when about 70% of the population currently has overweight or obesity. So that would be, incorporating larger gowns, larger vaginal speculums, larger weights that can accommodate patients, having posters or magazines that aren't shaming the body habitus. Now, going into obesity as a disease, it is recognized as a disease. In 1998, it was recognized as a disease by the NIH and by the American Medical Association not until 2013, so not even 10 years ago. It is a chronic and relapsing disease and lifelong. It has plateaus and regain. And you can compare it to other diseases like hypertension. If we have a patient with hypertension and we're trying to treat that, we don't say you have to diet and exercise and lose weight first before we offer medication. And when a therapy doesn't work, we don't blame the patient. We readdress to find out if it's a side effect of the medication or other barriers such as cost or social determinants of health that may be contributing to the lack of success. And now as a disease also, there are lots of factors that contribute to obesity as a disease, including the genetics and epigenetics, environmental or social issues. There is the endocrine and immune system, but also medical or medications and the neurobehavioral aspects too. And I won't get into the complete pathophysiology of obesity, but when you go into the hormonal aspects of it, it's really eye-opening to see how complex it is. And you can start to see where therapies and our traditional thoughts on obesity can sabotage the patient's success. So obesity becomes a disease when it is when we're able to diagnose it, which often, most commonly, we diagnose it by the body mass index or BMI. I'm not going to go into that in detail, but there are other ways to diagnose obesity, but they can be more time consuming and also more expensive. So we'll be more referring to the BMI as the cheap and fairly reliable source of diagnosing obesity. And then with obesity, we can categorize some of the comorbidities into the adiposopathy, or what we call the sick fat disease, versus the fat mass disease. So this slide kind of goes into separating them out a little bit further. The adiposopathy or sick fat disease is what is going to be more the metabolic issues, whereas the fat mass disease is going to be the physical forces or the aspects of compression from the excess weight. Now, obviously, this slide is very heavy and has a lot of information, but this lists a bunch of the comorbidities that come with the sick fat disease. But we are familiar with most of these, as they are the metabolic diseases, including hypertension, diabetes, hyperlipidemia, dyslipidemia, fatty liver, gout, renal disease, inflammatory disease, and weakened immune system. On the right there, though, it also lists the cancers that can be increased in the setting of obesity. And it is now thought that obesity is the second most common preventable cause of cancer now. Here are some of the examples of the fat mass disease, which again is going to be from the physical forces and compression of the excess weight. So we can often think of the compression of the upper airways can cause obstructive sleep apnea. Compression of the abdomen can cause dyspnea or hypoventilation, reflux, hernias. Excess skin folds can lead to skin infections. And then also, since obesity is a disease that people can see, it also causes those psychosocial issues, depression, low self-esteem, body image disorders, the biases that we previously touched on. And the patients really can start to internalize these negative biases themselves too. And so with all of these comorbidities, you can see where it is very important for primary care to be able to readily address obesity as a disease. Now, moving on into the treatment of obesity, it is complex and it is not a one-size-fits-all. These include the 4 pillars from the Obesity Medical Association, but we're including a 5th one, bariatric surgery, that I'll touch base on today. But these four pillars include nutrition, physical activity, behavior therapy, and pharmacotherapy. And each of these has a different role, and they can act as its own little piece of the puzzle in the treatment of obesity. And each one has a different effect and benefits that the other pillar may not have then too. So starting off with nutrition, there's lots of ways that we can identify unhealthy eating habits for patients. Sometimes we can do the dietary recall or diaries referring to dietitians. I'll say that with caution because not all dietitians are going to be sensitive to obesity. And you can also ask generalities of their nutrition, such as how many meals do you eat in a typical day? What's the biggest meal of the day? How often and when do you snack? What do you drink during the day besides water? But also a simple question that can be eye-opening too is just asking the patient, what is the least healthy part in your diet? So there's also a lot of different dietary interventions that each have their unique benefits and may fit into a patient's lifestyle a little bit better than the others. And we won't go into these fully today, but low carbohydrate diet can be helpful. I hesitate with the low fat diet, as oftentimes the low fat diet gets turned into more of a high sugar diet then. So I like to classify low fat diets as the low unhealthy fat diets. There's also the calorie restricted diets, nutrient focused diets. Meal replacement is an option as well as intermittent fasting or time restricted eating. The principles of general healthy nutrition is going to be the limiting highly processed foods, such as the junk foods or sweets, and limiting the sugar sweetened beverages, juices, and the other drinking of calories, increasing healthy proteins, fats, vegetables, eating complex carbs over the simple sugars, having higher fiber foods over lower fiber foods, and really really encouraging the quality of the calories as opposed to the quantity of the calories. The Obesity Medical Association has prescription nutrition pads that are available on their website. So I just took a picture of what I have here too. That can be a simple little prescription to give to the patient with their nutritional plan. Now moving on to physical activity. I think we're all familiar with the recommendations that for general health, people need at least 150 minutes of regular physical activity in a week. However, when we're talking about for weight loss or weight maintenance, preventing weight regain, it's going to be more along the lines of 300 to 450 minutes of physical activity in a week. And in addition to the aerobic or the cardio aspect of physical activity, the weight training or resistive anaerobic strength training is also important, and they have different benefits for each one. And as I mentioned earlier, notice how we're referring to it as physical activity and not exercise. So basics of physical activity is not just, going to the treadmill at the gym and doing things that you don't enjoy. You want to find things that patients enjoy and can keep doing. So if they like doing housework or walking or gardening, anything that gets their bodies up and moving, they can do that with the physical activity in their leisure time. But there's also the importance of what we call NEAT, or non-exercise activity thermogenesis. And that can be viewed as like the physical activity of daily living. So people who fidget are going to have higher NEAT than people who don't fidget. If you choose to walk the stairs, that's going to give you more than if you choose the elevator, escalator. Carrying things as opposed to having things be carried for you. So I think we're pretty well attuned to trying to figure out these ways to bring in a little bit more activity in our daily lives. Moving on to the behavioral modification. This one is the one that can be trickier to incorporate, because this is going to be the more time-consuming aspect. It takes a lot more focus, time, counseling, and skill too. I've included the ways of kind of assessing readiness for change for patients, which I think most people are familiar with that and can kind of parallel that with smoking cessation. And behavioral modification really incorporates motivational interviewing too. The obesity algorithm has what we call the 5 A's of obesity management. Versus asking permission to talk about weight. And this is going to be not just bringing up and just talking about their weight issues, but asking permission first. And I personally even start this early with my well child checks. I ask permission to review their weight charts and go over it with them too. So getting into the habit of asking permission, because some people don't necessarily want to hear it and aren't ready to hear it. And if you do push it on them, it can be that bias that we talked about earlier that's going to turn them away from seeking medical care. Assessing the obesity as a disease, so diagnosing obesity and finding the comorbidities associated with it. And then even advising the patient on the benefits of even a little bit of weight loss, even 5 to 10% of weight loss. And then trying to arrive and agree upon reasonable expectations or behavioral changes that the patient feels that they can incorporate into their lifestyle, and then help to arrange or assist, whether it's referrals or follow-up. During the behavioral modification, this is also important to kind of address or figure out why patients eat to help kind of develop a treatment plan. So we have lots of reasons why we eat, whether we're hungry. Some people will eat due to emotions, whether it's happy or sad. In times of stress, eating is a very social aspect for many cultures and for many people. Obviously, it can be very enjoyable, and we can use it as rewards for celebrating successes, or sometimes it's just out of boredom or habit. So it's really important to figure out what is contributing to patients' food intake to help identify the behavioral changes. And again, here, the Obesity Medical Association has a behavior script pad that helps to kind of go through that and give the patient a prescription on ways to help their behaviors. Now moving on to medications, which I'm sure everybody is anxious to hear about. There are a handful of FDA-approved anti-obesity medications. The indications are people who would qualify for anti-obesity medications are people with obesity, so a BMI of 30 or greater, or people who are overweight with a comorbidity, so a BMI of 27 or above. And then a comorbidity that we mentioned earlier, so diabetes, high blood pressure, high cholesterol, those types of things would be qualifying too. I'm not going to go into the specifics of each medication on their percentage of weight loss, but there are variable amounts of weight loss per medication. And there are some people who respond normal, which would be about the 5 to 10% weight loss with the medication. Some people are hyper responders and can get more weight loss. And other people are hypo responders or get less than 5% weight loss or even experience weight regain. If there's no clinical improvement with one medication, so we typically say about 3 to 5% of weight loss after 12 to 16 weeks with the one medication, can reevaluate to obviously see if it's a compliance issue, can the dose be increased, or switching to a different anti-obesity medication. So starting off, I am including the generic names, but a lot of people are familiar with the branded names too. So I'm including the brand names with these. I think a lot of people are most familiar with phentermine. It's been around for quite a while and is generic and the cheapest of the options. It's a sympathomimetic amine. It is a controlled substance, a Schedule 4 stimulant. Technically, it is only approved for the use for 12 weeks. However, there are plenty of safety data and studies that show it is safe for long-term use. There are different regulations by state, which South Dakota, which I'm the only one, or that's where I am licensed and obviously is approved for up to 6 months, and then they need a physical script. Phentermine is approved for age 16 and above. I forgot to mention too, a general caveat with anti-obesity medications is that they are all contraindicated in pregnancy. So I haven't necessarily included those contraindications, but I do want to make that clear too. Phentermine can be beneficial for people who feel hungry all the time, or they feel like they have low energy since it's a stimulant. If you do have a way to measure metabolic rate and they do have a lower metabolic rate, it can be beneficial for those people. Side effects include increased heart rate, headache, anxiety, irritability, tremors, or sleep disturbance. And it's contraindicated in people with cardiovascular disease, within 14 days of the use of an MOAI, in glaucoma, agitated states, or drug abuse. Again, stimulant that's a scheduled controlled substance. Moving on to phentermine and topiramate, it is put into an extended release form and branded as Qsymia. It's a sympathomimetic amine with topiramate, which topiramate has an unclear mechanism of action for weight loss. Because of the phentermine, it is again the Schedule 4 drug. This one is approved for long-term use, and it is beneficial for people who have excess hunger or who may benefit from topiramate with use for either seizure disorder or migraines. Side effects are going to include those that we mentioned with phentermine, but then with topiramate, you can get the paresthesias, dizziness, bad taste, constipation, dry mouth, cognitive impairment. Also can increase creatinine with the topiramate also. This one I did include, it is contraindicated in pregnancy and lactation because of the topiramate. And then it's also contraindicated in those with active cardiovascular disease, end-stage renal disease, uncontrolled high blood pressure, glaucoma, kidney stones, liver disease, and again, within the 14 days of use of MAOIs. Next one, Orlistat, over the counter. It is available as Ally or prescription at a higher dose as Xenocol. This one is not a very commonly used one. It's a pancreatic lipase inhibitor that blocks fat absorption. It is approved for long-term use, and it is approved for ages 12 and above. Like I said, it's not very commonly used, but it may be beneficial for people with high cholesterol issues or increased cardiovascular risk. It's not commonly used because of the side effects, which can be rectal discharge since you are not absorbing the fat. It can also promote gallstones and kidney stones, and also may lead to malabsorption of fat-soluble vitamins. So it's going to be contraindicated in the malabsorptive syndromes or with gallbladder disease. Psyllium may help reduce the side effects, but again, this is one that's not commonly used. Liraglutide or Saxenda. We're getting into the GLP-1 medications, which this one, most people may know it as the diabetes medication Victoza. So the GLP-1 receptor agonist, it's approved for long-term use, and this one is approved for ages 12 and above. This will be beneficial for use, obviously, in people who have diabetes, metabolic syndrome, or even people who feel like they have insatiety or can eat and never feel that fullness. Side effects with the GLP-1s can be nausea, vomiting, upset stomach, abdominal pain, diarrhea or constipation, increased lipase, headaches, fatigue, or renal insufficiency. It is contraindicated in people who have personal or family history for medullary thyroid cancer, MEN type 2, and those with chronic pancreatitis. It should be discontinued with suspected pancreatitis or gallbladder disease also. Now, I won't kind of go into the specifics again about the GLP-1s, but semaglutide or Wegovy is the newest anti-obesity medication. Again, most people know this as the diabetes medication Ozempic. It's a once weekly injection as opposed to the Saxenda's once daily injection. This one is approved for long-term use, but does not have that pediatric lower age. So it's only 18 and above. And again, very similar side effects and contraindications as we talked about with the Saxenda. Going on to the next one, naltrexone and bupropion is branded under Contrave. Naltrexone, opioid antagonist, and bupropion is an antidepressant that stimulates the hypothalamic POMC. This medication is approved for long-term use in adults, and it can be helpful or beneficial for people who have excess cravings, who struggle with emotional eating, or because of the bupropion in use for people with depression or smoking. Side effects can include nausea, vomiting, constipation, headache, dizziness, sleep disturbance, dry mouth, and even glaucoma. So it's contraindicated in glaucoma, eating disorders as anorexia and bulimia, uncontrolled hypertension, seizure disorders, again with the use of MAOIs. Because of the opioid antagonist, you don't want to use it with people who have chronic opioid use or people with drug and alcohol withdrawal. So those were the big ones that are actually FDA approved for anti-obesity treatment, but I will mention a couple other medications. Setmelanotide is a medication that is approved for the treatment of obesity in children ages 6 and above with a genetic obesity syndrome. And the 4 that are approved for the genetic issues are the POMC, PCSK1, the leptin receptor deficiency, and the Bardet-Biedl syndrome. This is a daily injection also. And then I'll also mention tirzepatide, which just came out as Mounjaro for treatment of diabetes. It is a GLP-1 with a GIP property to it. It is currently approved only for the treatment of type 2 diabetes, but the weight loss effects seem to be surpassing those of our other weight loss medications. So we anticipate that this is going to be approved for an anti-obesity medication in hopefully the near future. And it is a once weekly injection, similar to the Wegovy. Moving on to options for bariatric surgery, we'll touch on this briefly. People who are candidates for bariatric surgery are those with a BMI of 35 or more with one adverse health consequence related to obesity, or people with a BMI of 40 or greater with or without a comorbidity. Obviously, as primary care, we have to rely on our bariatric colleagues to help with the surgical consultation for this, but we can provide medical evaluation for caring with the patients. And then they all often have to go through the mental health assessment, nutritional assessment, and educational support, which often is done in a bariatric center also. I've included this slide about the various forms of bariatric surgery. Most commonly, we tend to see the sleeve gastrectomy or the Roux-en-Y gastric bypass, although on the bottom, the duodenal switches are starting to come up a little bit more because there's a little bit more weight loss with those. Gastric banding or the lap band has really fallen out of favor as it was originally least invasive, but it often ended up having too many side effects and needed resurgeries to remove it. So those have really fallen out of favor then too. So I've included basically my reference with the obesity algorithm. But if you are interested in learning more about obesity medicine, the ABOM or the American Board of Obesity Medicine has certification pathways if you're interested in becoming certified. There's 2 different pathways to do that. I did the CME pathway, which included doing 60 hours of CME activities that needed to be approved within an 18-month time frame, and then taking a board exam that's offered once a year. There's also a fellowship pathway too. So if you're interested in learning more, you can visit the abom.org. And like I mentioned earlier on in the presentation, the Obesity Medicine Association is a very good resource for clinicians. They put on medical conferences live in person, but they often also record those and they're available to view as a live stream also. They typically do twice a year conferences and they are excellent, having been to them myself. They also offer online CME and webinars, and they put out a obesity journal called the Obesity Pillars. There's also the obesity algorithm that you can download and review, which is a good resource for a lot of obesity information. But then also, like I talked about, they do have office forms and tools that are available to purchase also. And that will conclude my presentation. So if anybody has any questions, I will be happy to answer them. Okay, I see a question about, I find cost to be a limiting factor for medications. Any tips? Which that is a very difficult aspect. Now, some of these medications that I mentioned, like I'll use the brand names, the Contrave and the Qsymia. There are online pharmacies that you can send that typically can get the medications for about, last I checked was like $99 a month for them. But honestly, a lot of the time, since they are generic medications branded together, I do prescribe off-label the generic versions with as close to the medication dosage that you can get based on the actual formulation of the prescription branded medication. But that again is also why phentermine tends to be one of the more common medications, since it tends to be a cheaper medication, but we use a lot of off-label medications by doing the generics. Another question, do you have experience with Plenity? I do not. It is branded as a medical device, and From what I understand, it needs to have a certain license or a certain education to get that approved. So I have not done that, but I'm not completely sold on Plenity itself. Okay, generally, what is the youngest patient with obesity that you have seen? So obviously I'm in primary care and I do full spectrum. So I have kids who struggle with obesity, and the Obesity the Medicine Association does have its own pediatric obesity algorithm too, which I didn't really touch base into here, but a lot of the times for my peds patients, it is really trying to do more of the preventive cares. And a lot of the times it is making sure that they're doing the 5-2-1-0. So 5 fruits and vegetables a day, limiting the screen time to less than 2 hours a day, at least 1 hour of physical activity a day, and then 0 sugar sweetened beverages a day. So I tend to, with kids, tend to go more into that aspect of treatment, but there is a full separate treatment algorithm for pediatrics that I did not go into today. Is soda a common beverage with patients? Yes. A lot of times we struggle with the soda intake as the sugar sweetened beverages and the calorie intake, which a lot of times too, even the diet sodas, even though they're artificial sweeteners, they can still mimic a response to the body that almost mimics the sugars. So it can play a role into the hormone signaling in obesity also, or weight gain. So yes, we commonly see soda or pop being a common component in obesity treatment. And for a lot of people, it can be a difficult habit to break, almost as bad as smoking.
All right. Well, thank you for presenting today. Unless there are any other questions, I think that'll wrap it up for this time. Thanks, Dr.
And I finished on time.
Nice job.
Thanks everybody for showing up. And if you have any questions, feel free to reach out to me. You can always email me, or if you have my cell phone number, feel free to text me.